Welcome to Be Well, an It's Okay webinar designed to promote and support mental, financial, physical, and social well-being. Be Well provides insights, tips, and strategies for enhancing all aspects of well-being through conversations with experts. Whether you want to manage stress, improve your financial health, boost your physical well-being, or enrich your social relationships, this webinar is a go-to resource.
Thank you everyone for joining us today for what will be an exciting exploration into women's health at various stages of life and what you need to know to take charge of your health and wellness journey. As you may have noticed, Kate Fisher is not with us today, but I'm going to do my very best to step into her shoes and lead this conversation with Dr. Lakia Tucker. For those of you who might not know me, my name is Michelle Daniels, and I'm currently the Total Rewards Operations Global Program Leader. I've been with Cummins just short of 4 years. It'll be 4 years in October. Time really flies. And I began my time here as the Global Health and Wellness Administration Director before transitioning into Total Rewards project management, and now oversee the operations for our global programs, of which wellness is included in that portfolio. Prior to joining Cummins, I led benefit and wellness programs for over a decade at companies in various industries such as media, clothing and apparel, and cosmetics. I've been increasingly impressed with our It's Okay campaign since joining Cummins, and it's been really great to see the expanded focus into all aspects of our well-being. So I'm really excited to be here today to guide this discussion. Without further ado, I want to introduce our guest, Dr. Lakia Tucker. Dr. Tucker is a board-certified OBGYN with over 2 decades of experience in women's health. For the past 23 years, she has worked in private practice, supporting women through every stage of life, from adolescence to menopause and beyond. This work is not just her profession, it's her calling. She believes that informed women are empowered women, and she is truly excited to be here with all of us today to discuss the issues that matter the most to our health and our futures. There will be plenty of time as we go through. Towards the end of the presentation, we'll get to some Q&A. So please be sure that you use that feature to ask your questions. Additionally, feel free to engage using the chat feature throughout the presentation if need be. So just a quick summary. There's so much that we could cover about women's health. So we're going to try to touch on as many different topics as we can. And as I mentioned, still allow questions, time for your questions to be answered at the end. We'll begin by discussing women's health needs at different stages of life, and then explore some practical advice for women across all age groups. We'll talk, of course, about reproductive and hormonal health, and then we'll conclude with some practical advice on disease prevention and mental health. So that's a lot. It's a hefty agenda to undertake. So we're going to go ahead and get started. And as I mentioned, we'll have time for questions at the end. Dr. Tucker, before I jump into the questions, is there anything that you want to add or say just to kick us off?
Thank you, Michelle. I'm so proud to be here today. I think this is so dynamic that you do this for the company, and just to be able to provide such great information and a foundation. So again, like you said, this is my passion and I'm happy to be here. So looking forward to the questions that come forth.
Great. So the first section we're going to kick off is health across life stages. So we're going to start talking about women in their 20s and 30s. So the first question, when we think about this age cohort of women, how can women establish a routine that supports both mental and physical health amidst busy schedules and different priorities and family members and all of the things that women tend to be involved in? How can we establish a routine?
Thank you, Michelle. So in the 20s and 30s, they're building the foundation. This is the time that it's really pivotal, and they're building these healthy habits for a lifetime. So it's important to try to establish that balance. So you have to think about having a network, having people around you, having a village of people who are able to help you be accountable for those things that you need to do, such as exercising regularly, eating healthy, taking care of yourself to be ready to be a gatekeeper, to be able to take care of not only yourself and, potentially a family that you're ready to build, potentially, if you haven't already started that family. Thinking about those things like the preventative health and, just thinking from head to toe that we need to take care of ourselves. So it's important from adolescence all the way through through the ages that you have to think from head to toe to take care of yourself. So balance.
Great. And a bit touching on kind of what you just mentioned as well. So when we think about preventative medicine and think about, prioritizing health in those decades, are there specific health screenings or checkups that women in these age groups should prioritize to start that foundation?
Absolutely. So going to a primary care physician regularly is very important. There is a document that will be uploaded in the chat. It's from the Women's Preventative Services Initiative, WIPSI. And it's also on the It's Okay website. You'll be able to reference that there. This is a good guide to be able to reference so that you're able to see what preventative screenings are necessary for all age groups. Specifically, though, if we talk about in the 20s and the 30s, one of the things that we think about are pap smears. This starts at age 21. Sexually transmitted infection screening, dental screenings. We don't think about that very often, right? We don't think about going to the dentist regularly every 6 months. Taking a break from, digital health. We're on our screens. We look at these screens. We're looking at them right now. But, taking a break from that kind of thing. So we have to think about those kinds of things. So certainly going and getting those screenings and finding out what your family physician would recommend on a regular basis specifically for you. There's a number of different things that, based upon your history in particular, that your doctor or your provider, healthcare provider, may recommend specifically for you.
Great. We're going to get later into a deeper dive onto perimenopause and menopause, which is a huge topic for women in the 40s and 50s. But first, let's address some practical health needs for those in their 40s and 50s as well. So same question, Dr. Tucker. As we think about moving from 20s and 30s, how do the screenings or the regular health checkups, what changes, as you go from your 30s to your 40s and beyond? What else should we be looking out for?
Absolutely. So some of the same things are applicable, such as exercising, eating a healthy diet, but also you think about taking some calcium, 1,000 to 1,200 milligrams per day, more vitamin D, making sure that you have that to absorb the calcium, so 600 to 800 international units per day. So thinking about that. Making sure that you're getting enough of the diet, the healthy, balanced diet. Making sure that you're exercising well so that you're able to build the strength in the bones as well. The other thing is, we always have to think about lifestyle things, and this applies not only to the 40s and 50s and beyond, but also to the 20s and 30s, is thinking about, not having an overabundance of alcohol, not smoking, those kinds of things. Because you want to make sure that it doesn't, hurt your bones. And the other thing is perimenopause may start to creep up, and I'm sure we'll address that. We think about the various symptoms that you can experience with perimenopause. You may start to experience those within your 40s to 50s.
When we think about our 40s, how does metabolism change during this period? And what are some strategies to support healthy weight management and kind of either combat or work with, that metabolism shift that can occur as you approach your 40s?
So, Michelle, this is a big one. I feel like, people come into the office and they talk about, um, you know, the weight that they start to gain with that perimenopause, menopause, and that metabolism slows down significantly with perimenopause and menopause. We notice at least about a 5 pound weight gain per year if we don't do anything differently. And so we certainly need to do something different as far as those lifestyle things that we just talked about. And so certainly it definitely slows down. So we have to watch, some of the fats that are going in. We have to watch and make sure that we're putting the good fuels into our body to be able to help with that.
So as we move beyond our 50s into, perhaps approaching retirement age and again, other changes of life, what are the key steps to support mobility, balance, and maintain overall physical health in later years?
So when you talk about the seniors, they have to really watch as far as making sure that they're protecting their homes and making sure that, they're watching as far as, slip and fall kind of things like rugs and, things like that. And not tripping hazards and things. Um, but certainly the strength training is key. Making sure that they're, able to continue with, some weights and bands and, body weight exercises. There's chair exercises. I love that, some of the local gyms offer programs that are free to seniors. So that makes it easy for them to be able to continue to, preserve that muscle that they so need to be able to do. Yoga, those kinds of things. Non-weight bearing kinds of things, but certainly those light weights will help. Any stretching and all of that kind of stuff. And definitely you can't discount the power of walking on a regular basis. It's free. I say just go right outside, and that's for all of us, that we can go outside and go on a good walk and, build that community, that sense of community. That really helps with everyone to be able to stay connected.
Great. And then kind of shifting into, so we talked about keeping, the physical body mobile and agile and stretching. And what about cognitive decline? How can older women, prevent cognitive decline, maintain sharp mental acuity, keep those brain juices firing? Any guidance that you can offer there?
Absolutely. So definitely doing puzzles, there's, Sudoku, there's definite repetitive kinds of exercises, not just the physical exercises, like you said, but the mental exercises. Doing things like that, staying connected with people, group exercises, walking with your friends, boosting that motivation, because I think it's so key to have that, again, accountability and connection with community. And it'll help to be able to prevent dizziness and weakness and that sort of thing, and help with coordination. So anything that really just keeps them connected like that.
Great. Thank you.
Mhm.
All right, so let's shift the discussion to reproductive and hormonal health, which is, of course, a broad topic, but one that is on our minds a lot and probably, throughout every stage of a woman's life is something that she's thinking about or managing. So let's highlight some areas that affect us as young, middle-aged, and also older women. So, the first question here, what should women consider when planning for pregnancy to ensure optimal health for both mother and child?
So one of the main things that I say to patients is to, take their prenatal vitamin early, especially when they're planning for pregnancy. And that helps to build a healthy foundation for the pregnancy. That helps to prevent nausea. It helps to, give the nutrients that they need for the pregnancy. So that's one of the main things that they can do as they're thinking about that kind of thing. I think that just in general, just being healthy throughout the pregnancy, I think that's where you were leading with you were asking a question about what can they do to build that foundation, correct?
Yep. And when planning for pregnancy, right? How can you kind of be, I guess, at optimal health pre, during, and probably even post?
Yeah, so I think that, definitely that those are the main things is taking the vitamins in advance. I was thinking, if someone is having, if they're planning in advance, like egg preservation and things like that, they can do that kind of thing, but that's on a whole different scale of things.
So you've touched on it a bit already, and I don't know if this is necessarily the case, but it seems like perimenopause is being talked about more. I don't know if it's more prevalent younger, or again, it's just sort of in the lexicon more lately. But can you talk to us a bit about the differences between perimenopause and then menopause?
Sure, absolutely. So perimenopause typically begins in the 40s, and it can be something that lasts about 4 to 8 years or longer. It can start earlier in some populations, but typically the average age of menopause is 51 to 52 years of age. And when we talk about, some of the symptoms that you can see, most of us have experienced a lot of these things. You can have hot flashes, night sweats, mood swings, brain fog, memory issues, weight changes, vaginal dryness, changes in libido. The list goes on and on, anxiety, irritability, the list goes on and on. So, periods become, more irregular. They can be longer, they can be shorter, they can be heavier. And so those are changes that you see with perimenopause. Now, as I said, that the definition of menopause, I didn't say this yet, but the definition of menopause is when the period stops for 1 year. So 1 full year of no cycle. Now, what I get is when patients come to the office and they've gotten to almost that 1 year and they're like, Dr. Tucker, I started bleeding again. And I'm like, I'm so sorry, but your path is starting all over again. You got to
Right.
start that clock all over again. And so that's pretty frustrating for patients, right? So, I feel like, it's kind of this vicious cycle. And so with menopause, you can have some of the exact same symptoms that you have with perimenopause. And there's some, long-term risks that increase with menopause. And that includes, osteoporosis. There's more heart disease. There's more of the changes with possibly leaking of urine, because of the vaginal dryness that's noted, things like that. So there's so many things. But we see those changes in the hormones, and so we blame our hormones for everything. But here, the estrogen and progesterone drop, and they're definitely in play. So
And then you said, so if perimenopause is 4 to 8 years, menopause hits at 51, 52 on average. How long, I guess if you hit that year, but how long are you technically in menopause?
yeah, once you hit menopause, it's variable for different people. So, some women don't experience any symptoms. And, really I'm like, oh, that's phenomenal. If you haven't experienced anything, you just hit it and you're done, right? But most people experience something that's on that list of things that I talked about. Um, on average, though, I think most people are within it, probably within about 5 years. There's some range of, 2 to 5 years, I would say that they, have something, and it sort of gets better within that 2 to 5 year period. If they usually do something about it, and that something is variable per patient.
And then what are the challenges sort of post-menopausal health? So I think you kind of just already touched on that, but what can you do to address sort of the post-menopausal shifts in health?
Yeah, I think that, really following up with your healthcare provider, to make sure that you're addressing, what your symptoms are. I usually like to follow and say, okay, what are your top 3 things? Because, that way we feel like we're hitting something. That way we're taking care of something, if you will. So when patients come in, they have a list, right? And I'm good with the list. I'm like, come in with your list. I'm ready. I've got, kind of a checklist of things that I need to address at a certain visit, but I want to make sure this is your visit. I'm here to take care of you. And so I want to make sure that what you come for, that I'm actually taking care of you. And so, but we do have to kind of streamline it because we do have time constraints, of course. I wish we had all the time in the world to be able to see patients, but unfortunately, we don't have all the time in the world. So to narrow it down to the top 3, seems like it's more palatable. So then when we do a follow-up, so if you say that, hot flashes are really bad for you, and then you've also got, concerns because you're leaking urine, in your vagina's, your vagina's dry. So then we can say, okay, well, are you a candidate for, estrogen progesterone therapy because you have a uterus, and, maybe we do a little vaginal estrogen after, we do an exam or whatever, and we decide that that's what we're going to do. And then we say, follow you back up in a few months to check up on you and see how things are going. And then, when you come back, then you can say, what % are you better? So then we can say, do we need to adjust something, or, change the course of what we've chosen to do with shared decision making.
Great. Um, Moving on to disease prevention. So what are the most significant health risks that women face across their lifetime?
So the biggest one would probably be that of heart disease, right? Because that's the biggest killer for women, right? So that's one of the biggest things that we need to, prevent. So we've stressed this a lot throughout this, talk so far. We've got to get moving. We have to get moving. We have to be accountable to one another. We have to say, take care of each other as sisters and make sure that we're, doing what we need to keep our hearts healthy. I do think, though, that, breast cancer is super duper prevalent. So we do have to make sure that we're following up to keep each other accountable for going regularly, not only for just our regular exams, because we take care of everybody else. I always say we're gatekeepers of the families, and we, send everybody else for their things, but we don't go. And so we need to do that, but also for our regular mammograms when we're due for those. And I don't know if you want me to go through all of the guidelines for that at this moment.
That was one of my next questions. So you did that
Okay.
beautifully. At what age should women begin scheduling regular mammograms, and how often should they be done?
So typically, if you are a low risk individual, and that would mean that you don't have a relative who was diagnosed with breast cancer 5 or 10 years prior to the age of 40, you would go ahead and get your first mammogram at age 40 years old. And then the recommendation generally with most societies is to get a mammogram annually after that, and that's every year. And that's because the biggest risk factor for breast cancer is being a female and age. So we can't change those things, right? We're all going to get older. And if you're a female, you're a female. I mean, there's some gender affirming things and things like that, but it still doesn't change the fact that you were born as a female. So certainly it is very important. And men can also get breast cancer too. So that's very important to note as well. Oh, can I say one more thing about the mammogram? So the recommendation is to stop mammograms at age 80, and the reason for that rationale is that generally after age 80, that most of the time, patients aren't planning to do anything about their breast cancer if they were diagnosed at that point in time. So, what I normally will say to a patient who hits age 80, if they're wanting to continue with their mammograms, if they fall into that situation where if they would do something about a breast cancer, if it were diagnosed, I would say you can continue your mammograms if you choose to. So, it's not that you have to stop your mammograms at that point, but it is recommended that in a general setting that that's the recommendation.
Great, thank you. Kind of the same question. We had someone ask this, so I'll tie this in with the mammogram question. Similarly, how important are Pap smears? How frequently should women get them? And then, is there a similar age at which that's no longer necessary to have that screening?
Absolutely. Pap smears are really important. Pap smears in the general population start at age 21. And I know that for some people who are on this call, they may be like, well, hold on a second. I was so used to getting a pap smear like as soon as I became sexually active, or, when I wanted to get some birth control, or just, whatever. We don't do that any longer. We do a screening pap smear at 21 years of age, and then it's every 3 years until age 30. And then at age 30, it's pap smear plus HPV testing every 5 years. And these are in the low risk individuals. And then we stop pap smears at age 65 for patients. Now, there are special populations where, sometimes we do them more often than what I just stated. But, it's really just a discussion between you and your healthcare provider as far as like, do you fall into that special, situation? But generally, those are the guidelines that we follow.
Great, thank you.
Mhm.
Right. So that looks to be the extent of the questions that I had. It looks like we do have a good amount of questions in the Q&A. So I will move over. I'll start with those questions that we've got here. Um, what are perimenopausal options? Can't fall asleep, stay asleep, hot flashes, low libido for post triple negative breast cancer. Everything I've read says HRT is not an option.
Great. Yes. So I do think that, avoidance of estrogens would be the main thing. So you want to avoid anything that, so the regular HRT, that person is correct that they wouldn't want to be on that. But there are a number of different things for hot flashes that they can use, potentially, depending on, what other medications that person is on. But there are things like, antidepressants, some of the SSRIs, the selective serotonin reuptake inhibitors, they work really well to prevent hot flashes. Things like Effexor, that works really well, to prevent hot flashes. That's another antidepressant. Sudafed. It's simple. If you don't have high blood pressure problems, then that's another thing that may be helpful. There's a blood pressure medication that does help if a patient does have high blood pressure. It's called Catapress. That is another thing that may be helpful. Sometimes even simple things like, vitamin E. We've talked a lot again about exercise, just those natural, endorphins, and just, taking care of, just trying to help to combat those hot flashes. That helps a ton. Keeping, a cool cloth at the bedside, just, doing, cooling mechanisms, water to dip it in there and cool sheets, things like that. So there are a number of different things. There's also a medication that's out. It's called Veoza. You may have heard some commercials about that. That may be a non-hormonal option that is an option for that particular patient. And yes, I do see, yes, elimination, your diet. Your diet is another great thing, of course, just managing what you eat, avoidance of those carbs and things like that. I mean, that's certainly, what we put in our bodies affects us as far as how, our temperature is regulated. So we have to think about those kinds of things.
Follow-up question, kind of in the same topic as the HRT. It's become much more talked about. There seems to be a recent campaign that says that it's safe, where years ago the studies seemed to indicate many risks. How do you determine if you should or should not be taking it? What about if you're already in menopause? Is it still possible to start HRT? A lot of mixed signals from doctors and experts.
Sure. Thank you. In 2002, there was a women's health initiative study there that was done. And, back then, people came in and they just pulled themselves off of their HRT and they were super miserable. And that was all because of the study that was done. And it was basically saying that, there was an increase in, cancers and, heart disease and all the things. And that really related to, women who were in their, 60s who were on, HRT at that time. And so when we took a look back at the studies, we really found out that it really wasn't as bad as what we thought it was. And so that's where all of this information is coming out now. And so it is safe for most patients to take, menopause therapy is what we call it now versus, the HRT. And so, basically being able to take a look at the patient's profile and their medical history to be able to say, what are the risks and benefits for each particular patient, and then putting them on a bioidentical or a natural hormone, something that has, that's made from a plant. It can still come from, your local pharmacy. It doesn't have to come from a compounding pharmacy, but it can if the patient chooses to have it in that way. But both are bioidentical or natural hormones. So that is certainly an option for most patients.
Sort of the same theme, and apologies if you already mentioned this, but for women who cannot take hormones due to BRCA1 and or 2, what do you suggest for extreme hot flashes during the day?
So that falls into the same category for the last patient who actually had cancer, but this person, the BRCA1 and 2, may not necessarily actually have cancer. They may actually be a carrier of a gene that that's at high risk for cancer. So we don't want to do anything that, really kind of pushes them over the edge and gives them a cancer. And so some of those same natural things, the exercise, the dietary things, the things like the catapress, effects or the antidepressants, et cetera, any of those natural types things. The Veoza works really, really well for patients. So I feel like patients are happy with that. You do have to follow lab studies with that to make sure that it's safe to keep the patient on it. But that is something that is a FDA approved or Federal Drug Administration approved for hot flashes.
Great, thank you. We had a question. Would you be able to repeat the milligrams of calcium and vitamin D that you mentioned earlier?
Sure. It was 1,000 to 1,200 milligrams per day for the calcium. And then for the vitamin D, it was 600 to 800 international units per day. And that's at baseline. And that's just for general. Sometimes patients do need a little bit more if they are deficient in, vitamin D. So that level may need to be checked depending on, what symptoms the patient is having.
Similar question. This one's kind of a two-parter. You mentioned it a bit, but there was a question around seeing that there are health concerns when this cycle stops and returns. Is that alarming? Is that something that should be a watch out? And then part two, taking calcium and vitamin D, is that D3 or D2? And then lastly, I guess it's a three-parter, is vitamin K2 compatible with D3?
Yes. So I will say the first part, as far as if your cycle stops and starts, we need to know, are you bleeding heavy? Are you bleeding, about the same? Because if you start bleeding heavy, then one of the things that we might want to consider is uterine cancer for the patient. And so we may consider doing an endometrial biopsy, so sampling the lining of the uterus to ensure that there's no uterine cancer present. So that might be something that is discussed with you. But if it seems like it's just, light bleeding that started back up and you're, 51 years old, it may just be that, it's perimenopausal bleeding. It's very light and it's right along your cycle time. So again, that's a discussion that's right along with your doctor. So I think that just having that and always err on the side of caution, just to make sure that you take care of yourself. As far as the type of vitamin D, it's vitamin D3 that you want to take because that's the type that you need to absorb the calcium. And then as far as the vitamin K, some of the vitamin Ds, you'll see them with vitamin K in there as well. You've got to remember that the fat-soluble vitamins are, you may not remember because you've not been told, that the fat-soluble vitamins, now you'll know, are D, A, K, and E. So when I say fat-soluble vitamins, those are the ones that stick with you. And so those are the ones that you do have to monitor and make sure that you don't get too much of them in your system because they're not urinated out like the water soluble vitamins. So when you think water soluble, like if you get too much of it, generally you've got expensive urine. That's what I think of, you're just urinating that back out. But so just don't take too much of anything. Obviously, it's better to sort of consume it with your diet if you can.
Great. Some similar questions kind of around vitamins and supplements. So in addition to calcium and D, is there anything else you would recommend for women or not? I see some women who take multiple vitamins and just wanted to get an opinion. And then a similar question, is there an iron supplement that you would recommend?
Sure, thank you. I would say just taking a general multivitamin in general, it's going to give you mostly everything that you need. It gives you a balance. And there's no particular one. I mean, sometimes you can go on Consumer Reports and you can see, if there's one that's a little bit better than another, but I don't really advocate specifically for one particular multivitamin over another. There's a bunch that are marketed. I could tell you the one that I take, but I don't want to just be like, okay, I don't market that one specifically. Omega 3s are good things if you don't get enough, fish within your diet. I think that, doing something like that. The other thing is if you have, if you're anemic, certainly supplementing those various iron levels, so you have to kind of watch, and report your symptoms to your doctor so that you can say, are you fatigued? Have you been losing blood? Have you been losing too much? And if so, you can get those levels checked. You can get those, ferritin levels and B12 and, various things checked. If you don't eat meat, you can folate, you can get those, get all those things, checked. So then that way you can say, replace those vitamins as they are needed to be replaced. But in general, just a multivitamin and, the calcium, vitamin D, and then maybe an omega 3.
Great. Let's see here. A couple questions around bone density. What are the recommendations and coverage for bone density DEXA scans?
Absolutely. So generally, bone densities start around 65 years old. There are some populations who are at a higher risk um, for, bone loss. And so those patients need to get their bone densities a little bit sooner than that. So it may be somebody who's had a hysterectomy and has had, her ovaries removed. Um, Someone who's been on certain medications that may have stripped the bones, so there's certain populations like that. But generally it's menopausal patients that are getting their bone densities done. And then it's done every 1 to 2 years, depending on, what the findings are, if there's osteopenia or osteoporosis that's noted.
And kind of piggybacking off of what you just mentioned, besides calcium supplementation and weight bearing exercises, is there anything else that's recommended for preventing osteoporosis? And then, as you just mentioned, the bone density scans are not recommended until 65. Is there a reason why? Because the question asker mentioned that seems a little late, right? If you're trying to perhaps get in front of the bone density loss, what can be done prior to those screenings?
Right. So definitely the calcium and the vitamin D and exercise and, those kinds of things are the mainstays of prevention. And eating your diet, having your diet so that you're able to, put in, the calcium and build that, keep that bone nice and strong and built up. Certainly, are bone densities ordered sooner than 65? Absolutely. I think most of them are ordered earlier than that and actually probably covered earlier than that within that menopausal range. There are some mini screens that are done for patients where you can put a heel, your heel in a boot, like you may see it at some of the health fairs around town and things like that. And so sometimes if you notice that the bones are low from that mini screen, then you can take that to your doctor and you're able to say, oh gosh, my bones are a little bit low. And then it's covered in that way. There are certain medications, like I said, that patients are on that put them at high risk, that they may be premenopausal even, and that may be covered. So there are situations, so you don't have to necessarily fall into that category. So I don't want for anyone to feel like, gosh, I just have to be like falling apart to be able to get my bone density. We do have insurance and things like that to just be preventative.
Great, thank you. We've got a few questions around menopause and perimenopause. Um, how normal is it to lose all of your body's testosterone in perimenopause? My levels dropped to zero almost overnight, and I've heard mixed opinions about whether it should be supplemented to help with mental and physical health.
So it's not typical to see it drop to zero, but it is typical to see it drop low. And I typically like to treat the patient and not necessarily the number for any of the hormones. But when we see the testosterone levels, checking testosterone levels is usually to make sure that we're not over medicating you. So certainly, if this patient is having symptoms, low libido, things like that, I would say it's reasonable, especially since the level zero. And if there's no contraindication, nothing that says we can't start this medication in this patient, then I would say, let's try it. Let's see how she responds and then repeat her testosterone level, in a good, 4 to 6 weeks and see to make sure that we haven't over medicated her, putting her into a toxic range. And as long as we haven't done that, and hopefully she feels better, then she can continue the medication. So that's what I would say to do.
Thank you. What is the best way to replace cortisol in menopause? I feel no matter how much I work out or diet, there's no change.
So I don't typically check cortisol levels. I don't know if Dr. Chestnut does, but I don't specifically check cortisol levels specifically. So I may send a patient to a nutritionist um, for that.
Yeah, and, so cortisol, right, is highly dependent and fluctuates quite a bit for most individuals, and so it's typically not checked unless there's evidence for a specific disorder, right, for an adrenal disorder, and so typically it's not something that is checked frequently.
Thank you. When going through menopause, can an individual experience hair loss?
Absolutely. Because of the hormonal changes, that is something that patients can notice. So certainly taking something like a hair, skin, and nail, supplement, something that has, the biotin, collagen, those kinds of things within it. There are some specific vitamins that are marketed for that particular thing. And if not, sometimes following up with a dermatologist as well is super helpful.
What type of diet? I know you've touched on this a bit, but anything specific for a recommended diet for menopausal women?
Definitely lower in, the fatty foods, having, more of the proteins, less of the complex carbs, that sort of thing. Um, Having more veggies, that's important.
We have a couple of questions around how, when you go to your regular PCP, it's hard sometimes to get all the blood tests done that you'd like. And sometimes functional medicine doctors help identify the gaps with hormone replacement therapy. What are your thoughts about synthetic hormones versus bioidentical hormone pellet therapy?
So a couple things. As far as your family medicine doctor, one of the things that I find, and I have to explain to my patients when they come in, I'm a general OBGYN, and I feel like I have a great relationship with my patients. And sometimes when they say, gosh, I went into my family doctor and I feel like they didn't really order those things like you said. I ask them, what visit were you in there for? And so one of the things that they might say is that, well, I went in because I had this complaint, my back was hurting. Well, they weren't there specifically for their annual with their family doctor. They weren't there specifically to address those medical needs. Like even if it's a refill of your medication, um, and I think that the other thing is that the time on their appointment, they may have been in for a 10-minute back pain checkup, and so but their expectation was that they were coming in to get their back checked and to get their labs checked. But the doctor's expectation was, I'm going in to check your back and I'm out the door. I'm in there to do these things. And so we were in two different zones. And so I think that we have to make sure that we're in the same zone and that we're meeting each other's expectations. So I think that starting with, when you schedule your appointment, making sure that you talk with the front desk to say, these are my expectations. And if you need a 30-minute appointment and you're thinking you're coming in for, you want these certain things addressed, to make sure that you actually get that, because then that way that doctor can be teed up for success with you and you're on the same team, because you're really on the same team. So we're all together on the same team. So, so certainly that's where you need to start. So that's why when you go to the functional medicine doctor is able to, that's what you're there for. So they're going to take care of that problem. So they're managing those hormones or managing those things. As far as synthetic versus bioidentical hormones, you always want bioidentical versus synthetic. Whether it's in a pellet form, whether it's in a patch form, a gel, a pill, something like that. Generally you want to have bioidentical unless there's some other reason. I mean, some people, their insurance only covers the synthetic and that's all they can afford and that is it. And is it bad? No, it's not bad. It's just not the best. But it's not a bad choice if that's what they have to take because that's what they can afford. So, but if I had to choose, I would say a bioidentical all the way around, no matter what the delivery form is.
And you touched on it, but so in those situations, right, where you're going in, you're asking the doctor, and they're refusing to run the panel or do those hormone tests, are you saying that you would recommend a functional medicine doctor or a specific appointment with an OB? Like how can folks kind of, to your point, work with their doctor, work on the same team, but have that comfortability and ultimately get the testing that they're seeking?
Yeah, I mean, I think that it's a matter of communication. I think that you have to find whatever the doctor is, whoever the doctor is. It doesn't have to be a functional medicine. It can be. It can be a general OBGYN. It can be a general practitioner, family medicine. I'm not necessarily advocating for one specific over another. I'm saying that wherever it seems that this particular patient needs to get their needs met, and sometimes we think when we're the patient, if I was putting my patient hat on, right? Sometimes I come in thinking that this is what I want, but I don't have a full understanding of what I really want. But I need to have an explanation from my doctor to share with me the why behind things. And then we come to a shared decision making of what needs to be done for me at an appropriate visit. So it's a matter of just finding that good fit, if you will, for you, so that you can come to those good shared decision making for yourself.
Great. We've probably got time for a couple more. Is there a relationship between anemia and dementia in the later years? Do you have any recommendations to prevent those types of mental illnesses?
Sure. I think that when you think about anemia, there's a number of different causes for anemia. So there can be a deficiency because of the diet. So some people are, vegetarians or they just don't eat a balance of, certain foods. There can be, a fall. A person could have had a fall. So they may have a bleed, in their brain or something like that you're concerned about. So, or they're bleeding from somewhere. There could be having a gastrointestinal bleed or a bleed, from the vagina or just anywhere, right? So we have to think about why are they anemic, and try to treat that root cause for the anemia. So they would see their physician to be able to get to that root cause. But certainly being anemic can actually cause some of the neurologic issues as you've stated. But certainly getting to that root cause is key.
Yeah, and if I can share as well, so there's a lot of overlap between the two, and there's limited evidence that correcting anemia helps it as much, but they both can result in very similar symptoms and seem to have at least some kind of synergy toward worsening those symptoms. And so treating those each separately, as treating especially an iron deficient anemia or B12 deficient anemia, as well as doing protective cognitive practices to help delay the onset of dementia can be helpful. And so an approach to that, or a good approach to that, would be to do the two. Briefly, just want to reiterate what Dr. Tucker said. As practitioners, at least on my side, it is to never take offense if someone needs to find someone who is a better fit for them. I do my best to be a good fit for most people that I can, but a patient, doctors, providers, clinicians are there for the patient, and if we are not fitting a patient's need, we should never take offense at someone seeking care that does meet their needs. And so also want to strongly recommend, if your doctor is not a good fit for you, is not supportive in the ways that you want, then absolutely seek someone who is.
Thanks, Dr. Bob. This is an interesting one. Is there anything we can look out for in terms of risk of endometriosis?
Ooh. As far as risks, I mean, typically signs, you would say that the patient has, pelvic pain. That's one of the mainstays of endometriosis for patients. Um, Certainly their cycles can be, painful, heavier, irregular, that sort of thing. Certainly if they have a family history of endometriosis, so let's say their mother or their sister or aunts have had it, we can suspect it, especially based upon the symptoms that they are experiencing. Sometimes we'll start by, giving them, like a birth control or something like that, or, treating them with nonsteroidal anti-inflammatories or Tylenol. But, certainly it really depends on, what they're coming in and saying that what they're experiencing with their cycles or in between.
This is a good one. Do you have any thoughts or opinions on wearable health technologies, smartwatches, rings, etc., that give indicators on women's health? Are they reliable for monitoring health outside of doctor's visits?
Absolutely. I think that, we've really come a long way with our technology. And, I used to hand out a lot of menstrual calendar cards, but I saved a lot of money on that. So um, I'm grateful that we now have the technology that patients come in and they're like, here's my cycle. They show it to me and I can really see what their menstrual calendar looks like. I feel like that's helpful. The other thing is it's super helpful for, gauging fertility, and when are they, ovulating so that they can time out their, window for, best, able to conceive. And so, that's super helpful. Gosh, we even have, I've got an Apple Watch that, helps you to do an EKG. I mean, it's not going to be foolproof, but gosh, if you feel like you got a little something going on and you want to hit the smartwatch just to check it out, just to see. But certainly, looking at that health app, it's super helpful. And, you're able to use your technology to your, convenience. If you're going to purchase it, you may as well use it to your advantage.
Great. Well, thank you so much, Dr. Tucker, and thank you also, Dr. Bob, for joining and adding some commentary. This was a great discussion. I'm sure we could have gone on for another 30 minutes or so, but thank you again for joining us, and thank you everyone for joining with all of your questions. This will be recorded. I think we mentioned in the chat, but it'll be recorded. It'll be on the It's Okay website for you to review at your leisure. And thank you again for joining us today.